I'd like to talk now about small field dosimetry and its clinical implications. So there are a number of applications where we want to use very small fields in radiosurgery, for instance for functional radiosurgery, where we're using beams as small as just 4 millimeters in diameter. So there are some technical difficulties in measuring small photon beams and using them. So I'm going to divide my talk up into 3 sections. Firstly, we're going to look at the difficulty in measuring the output factor or the collimator factor. That's got to do with the relative loss of energy within a field compared with a reference field. Secondly, we're going to look at scatter outside of the primary beam, and that depends on the diameter of the beam and the beam energy. And then thirdly, we're going to look at geometrical accuracy, that's the location of the dose. And we know that smaller beams and smaller targets require a higher degree of accuracy. So if we look at the dosimetry of small photon beams, one of the important things to do is accurately measure the output or the collimator factor. Now we know that smaller beams lose some of their energy by scatter of secondary electrons out of the beam, and that means that the beam loses some of its energy at depth. The dose output of a beam depends on its diameter and its energy. And this reduction is reflected in the output or collimator factor. And you need this to be able to correct for the overall dose that you deliver or the irradiation time that you deliver in order to get the correct dose. Now there have been at least a couple of documented errors regarding this in Toulouse between 2006 and 7. Intracranial radiosurgery with the Novalis Linac was delivered with micro MLC and cones. Field sizes as small as 6 millimeters in diameter were delivered, and a hospital physicist commissioned a new stereotactic unit. Now, a pharma ionization chamber was used. That has a 23 millimeter active length to it, and it was used for measuring fields as small as 6 millimeters in length. Here we can see a graphical representation of that. On the chart on the left, you can see a red peak which denotes the 6 millimeter beam, and you can see above the active or sensitive volume of a pharma chamber, which is 23 millimeters. So you can see that not only that chamber was measuring the peak of the beam, but it was also measuring the penumbra and dose fall off on either sides of the beam. And in this chart here, which shows you the scatter factor that's related to the collimator factor versus the square field size, you can see very good agreement between what we call the pharma chamber and a much smaller, more accurate pinpoint chamber, more accurate for measuring these small fields. You can see a very good agreement between the two for field sizes above 40 millimeters. But once you get below that, you see a significant difference between the two. And once you get down to 6 millimeters, while the pinpoint chamber is measuring a scatter factor of around 0.5, the pharma chamber is about 5 times lower at about 0.1. Now this is an isolated occurrence. In Missouri, between April 2004 and 2009, intracranial radiosurgery with a micro MLC or cones was delivered. A hospital physicist commissioned the new stereotactic unit in 2004. There was no external audit. Field sizes as small as 6 millimeters in diameter were used, and an ionization chamber for measuring fields was greater than 6 millimeters in length. So this was almost identical occurrence, and 76 patients were affected and over-irradiated over a period of 5 years. Now things have moved forward significantly since those times in early 2000s, and there's now a lot more information that's been published. And in this paper by Tani, we can see here different chambers. We have 5 different detectors, and we can see here that correction factors are assigned to them. You can see the difference in response as the field size gets smaller and smaller, and this has all now been documented. And at a similar time, a paper by Alfonso and al. Proposed a new formalism for reference dosimetry, and proposed that different detectors could be assigned different correction factors to take into account their inadequacies in measuring the correct collimator factor for a given field size. So every detector can have its own specific correction factor to correct its reading to that for a reference chamber or for Monte Carlo calculations. And this table here shows you a list of the different factors that can be assigned. So you can see that they are significantly different because some chambers really can under-detect the true output factor. Some of them even over-detect the true output factor. And we repeated work similar to that for the Gamma Knife. We used 12 different PTW detectors, and we compared these with a liquid ionization chamber, which was our reference chamber. So you can see that some of these, the top one here, it's a large ionization chamber, so that has a correction factor of 2.6. So it shows that the active volume is much larger than the 4mm collimator. While there are other detectors here, the one at the very bottom, the synthetic diamond detector, which is very good indeed and measures the 4mm collimator to an accuracy of better than 1%. We can also use radiochromic films, and these are examples that we've used to commission the Gamma Knife, looking at the 4, 8 and 16mm diameter fields, and we can use those to calculate collimator factors. And these are some of the results that my group have obtained when they commissioned 5 different Gamma Knives, and you can see fairly good agreement between those. Let's look now at the scatter outside of the beam. Now, there's a paper here with a bit of a funny title, but this chart from this paper is very, very useful to demonstrate what I mean by scatter outside of the field. So here they're looking for disequilibrium in lateral electron transport. That basically means how many electrons are being scattered outside the field versus how many are being scattered inside the field. And ideally, you want to have good equilibrium of that lateral electron transport. So here I've applied a red line on this chart, which corresponds with an 8mm diameter field. And we can see here that for cobalt 60, the ratio of dose to Kerma is about 1, okay? And the ratio of dose to Kerma is the proportion of the dose that's not scattered out of the field. So that's good. If we look at, let's say, a 6 MV beam, that's really a bit too a higher energy to use for these small beams. And you can see that about 20% of the energy is scattered outside the field. This is at 5 centimeters depth. If you used an even higher energy, 10 MV, then it's more like 30% of the energy is scattered outside the field. So this is really important when we're treating with very, very small beams. So here's an example. This is a patient treated with trigeminal neuralgia with a 6 MV Cyberknife. We sent this patient due to some complications that developed. And if we compare this treatment plan with that delivered with a Gamma Knife, which has the lower energy cobalt radiation, and then we look at some lower isodose lines, we can see a significant difference. So with the 6 MV plan, the 15 gray volume is about 219 cubic millimeters within the brainstem. While if we look at the 15 gray volume in the brainstem for the Gamma Knife, it's just 4.4 millimeters. So that's 40 times lower volume in the brainstem. Now that's partly due to the construction of the plan, and you can see that that's quite different. It's more like a sort of a cross shaped with the Cyberknife versus a circular shape with the Gamma Knife, but a lot of that is due to the difference in beam energy. Finally, we're going to look at the geometrical accuracy and what that distortion means in practice. Well, when we're delivering radiosurgery, any geometrical error that we have means that we have the volume that we want to treat, that we see on our treatment planning system, and then we have in reality the offset volume that we end up treating. And you can see on the left here, the red line denotes a small vestibular schwannoma, the limits of the vestibular schwannoma, while the yellow line denotes the prescription isodose that we're using to treat that lesion. And then on the right, you can see what a 1 millimeter shift in the Y direction would mean to that treatment plan. Suddenly we're losing some of the tumor, and we'll be irradiating the cranial nerves on the anterior edge of this lesion. And we can work this out mathematically using two volumes. The volume of overlap between two offset spheres is this equation here. But we can then apply that equation for a number of different volumes that we might typically treat with radiosurgery. So you can see in this table here, we have the target diameter in millimeters versus misalignment. If you look at the bottom line, for a 30 millimeter diameter target, for a misalignment of 0.5, 1 or 2 millimeters, you still get at least 90% coverage. If we now look at the top line and a 4 millimeter diameter target, you can see even a 0.5 millimeter misalignment means that you're losing about 20% of your target. So you've just got 81.3% coverage. If you increase that misalignment to 2 millimeters, you're down to just 31.3% coverage. So in theory, the coverage of the target versus diameter would look like this. So this is applying a 1 millimeter displacement, and on the x-axis we have the target diameter in millimeters, and in the y-axis it's the percentage coverage after that displacement. Now we can actually apply, in this case, this short study has looked at a series of vestibular schwannoma plans, and I've applied a 1 millimeter shift in the y direction to those, and then I plotted those on the original chart, and you can see, interestingly, that the proportion of target that's still being covered is actually higher than that in theory. And the reason for that difference is because the plans aren't perfect. We have a certain amount of dose spillage outside the target, and that actually reduces the loss in target coverage that we might otherwise have. But you can see it's still quite serious if you're treating a very small diameter target. So to summarize, small fields are difficult to measure and require expertise and specialized dosimetry equipment. Secondly, out-of-field scatter can contribute significantly to doses outside the target. And thirdly, for a given geometrical error, smaller targets are more susceptible to undercoverage. Thank you very much for your attention.